Hi there and welcome to another Osler Roundtable. My name is Todd Fraser and I'm an intensivist here in Queensland, Australia. I'm delighted to host this roundtable as regional ICU has been a constant theme in my career, as it has for most of the guests joining me today. Penny Stewart is an intensivist and Director of Intensive Care at Alice Springs Hospital. For those of you who don't know, Alice Springs is one of the most isolated intensive care units on the planet, placed at the heart of Australia's desert interior. Paul Seckham is an intensivist who works with Penny at Alice Springs. Paul is passionate about Indigenous health and has proven high-quality research can be performed even in remote settings. Providing with a trainee view are Lauren Cox and Claire Corrigan. Lauren is currently in her first year of training, while Claire is about to sit her fellowship exams. Rob Bevan joins us to provide a college perspective as the Vice President of the College of Intensive Care Medicine. Rob oversaw the update of the training guidelines while the Director of Education for the college, which now sees regional training becoming a mandatory component of ICU training in Australia and New Zealand. Penny, I'd like to start with you if I could. You've been in practice in the remotest of rural intensive care use for many years now. What attracted you to that position in the first place, and what's your experience been with it?
That's an actually complicated question. The thing that attracted me really to rural and remote medicine was equity. I went to Alice Springs Hospital when I was finishing off my training to do a medical registrar job and realised that there were two types of Australia. There was rural, remote Australia and there was city Australia. And they weren't equal. They weren't equal with regards to healthcare services. And I looked at the people that I was looking after in Central Australia and realised that they were the sickest people I'd pretty much ever come across. They're also much younger, and that at that stage there was intensive care that wasn't good enough for looking after people, and people were dying of reversible disease as a result of it. And I thought there was two things I could do, is walk away from it and never think about it again, or do something about it. And then I went back to doing my city jobs, and 5 years later I got a call, and I thought, well, if I'm true to my word and I'm true to the fact that as an Australian, looking after Indigenous Australia was incredibly important to me, that I was taking on the advantages of what modern Australia was without taking on the complications and the problems that modern Australia had created for our Indigenous mob. There was also the other things that I liked. Alice Springs as a place, I thought it was a really beautiful place. I loved working in the country. I think that your life is much better if you can walk to work rather than having to drive a long distance. And I could see a sense of purpose.
Paul, I might throw to you, how difficult has it been for you to maintain your skills in Alice Springs in terms of staying up to date with literature, attending conferences and so on? What's been your experience?
So there's a couple of levels to that, isn't there? One is, I guess, maintaining procedural skills, and then one is maintaining sort of a currency of knowledge, and then maintaining a currency also of the slightly more unusual things that you might see more commonly in big centres. So I'll start with the procedural stuff, because I was listening to, and I hope I don't cross any lines here by cross-promoting another podcast. I was listening to Andrew Davies' podcast recently. I was talking to David Tuxon about almost the opposite of what you're alluding to. So Andrew asked David, how is it that consultants in big tertiary units can maintain their procedural skills when they have a queue of junior staff lining up to do them? And in many ways, we have the opposite problem in regional Australia. So, the opportunity to stick lines in or intubate comes up in some ways more often than is convenient or that you would like, but there is an intrinsic reward I think, and I still get a lot of enjoyment from getting that sensation of the needle entering the vein, that pop you get, particularly when you've done it well. And I guess when you've got a junior staff member standing next to the bed watching you do it, and you do it well and you do it slickly, and you just out of the corner of your eye, you see that face of the junior doctor going, wow, that was slick and impressive. And knowing you can do that and do it well is, I still get a kick out of that. The other things are slightly more difficult, and I guess what you tend not to see in the regional centres are the really complicated patients. And I'm always in two minds about whether I miss them or not. And I'm sort of thinking of the awful hematological disasters that I certainly looked after as a senior registrar in a big tertiary unit. And part of you misses that, and part of you also goes, actually, they're always really difficult and they often ended badly. So perhaps I don't miss that so much. So maintaining an up-to-date awareness of what's happening in that space can be difficult. What I can do at the moment is stay up to date with the literature. There will come a point, I think, where I will need to spend some time back in a bigger unit, and that can be done as part of a secondment or a clinical placement, as part of a sabbatical or something similar. There's a similar story around, I think, paediatric patients. We see just enough sick kids in Alice Springs that you need to know what you're doing, but not quite enough to be comfortable with them, if you're ever comfortable with looking after really sick kids when you're an adult intensivist. And again, maintaining that currency is a little difficult, but not impossible. We run a paediatric basic course at least every second year, so it's a chance to at least keep up to date with the theoretical side of things. We have a really strong working relationship with our paediatric referral unit, which is the Women's and Children's Hospital in Adelaide. And call out to those guys down there. They are always excellent, always happy to talk our way through a complex paediatric problem. And I think the last thing you referred to was conferences. It is difficult from regional units to get to conferences. There's a travel impost. So from Alice Springs to anywhere is 3 hours minimum, usually by plane, which means, and you're limited to one flight a day, which means you often have to arrive the day before a conference and then stay a day after a conference. So a 3-day conference turns into 5 days away from the unit. It's also away from your family. And it also means that somebody has to stay behind to look after the ship. And ensuring that happens in an equitable fashion can sometimes be a little bit difficult and challenging as well. So, that's not to say that it's impossible. It can be done. And I think increasingly now, one of the perhaps benefits or silver linings to COVID has been an increasing recognition that some of these things can be done in a hybrid fashion. And that's going to make things, I think, a little easier, but necessarily will miss out on perhaps the more important aspects of conferences and meetings, which is the networking that occurs between sessions.
Rob, I'll go to you. From a college perspective, there's obviously a renewed interest in regional intensive care in Australasia. You were part of the program that oversaw the changes to the training requirements that now require trainees to go through some level of regional training. What was the impetus for that?
Oh, yeah, I think, well, Todd, we've got, as colleges, we are entrusted by the Medical Council in Australia and New Zealand, and actually accredited to a pretty high standard in a process to train high quality specialists who can provide services to our communities. And that's through a combination of training and CPD. And we see our responsibility equally applicable to our communities, irrespective of where they are in Australia or in New Zealand. So despite the practical challenges, we as a college believe that, you know, all people in our country should have access to the knowledge and skills of an intensive care specialist. But we've got to recognise that what does access actually mean? Times they are changing, and that's never going to be overnight. But we've got a responsibility to all of our communities, not just the biggest cities in Australia and New Zealand. So how's, you know, we've had to do that. How's it worked? Well, I mean, the college really, we can affect supply to a degree, and it's a work in progress, but we've got pretty much a limited ability to determine the demand in the rural and regional centres. You know, and we've probably underexplored how we can encourage the redressing of this geographical disparity. But, you know, I think the other trouble is that training programs, we've brought this in through the 2014 curriculum reforms, mandating some rural exposure in some sense. But our training programs have got an inherent 6 to 10 year lag before curriculum changes can result in any meaningful data. And that can't keep us blinkered to the fact that we've got to adapt to feedback. So it really is a work in progress. But all training programs have to be an iterative process as the trainees, the supervisors, fellows, and the community indeed feedback on what works, doesn't work, where the gaps are. And quite rightly, we've got to focus on inequity, especially in those parts of the world where there's an increased proportion of Aboriginal Torres Strait Islander peoples and Māori and Pacific Island peoples, which, quelle surprise, is the more regional and remote parts of our countries.
Penny, just on that, in terms of recruitment, what have been the challenges for you as a director of a regional ICU in terms of getting people to come and work with you?
Yeah, the biggest challenge is the lead-in time until you can get recruitment. There has to be a trust in the system. It has to be a work environment that allows people to have a work-life balance. Most rural places have to convince their administration to have a kind of a 1 in 4 roster. And until you have a 1 in 4 roster, it's really difficult to encourage consultants to come. It's just, I did a 1 in 2 on-call for quite a long time. Not many people will do that. But once you can do a 1 in 4, that becomes important. The other thing is making sure that people have actually seen it in their training time, so that because you're always biased towards what you've seen. You believe that is more important. So if no one comes in their training time and sees the importance of what their work is, it will never be understood. And I think the other thing is that we really do need to think about other kind of activities so that 1 in 4 roster can be absolutely consolidated more in the non-clinical roles, which we do very well, like teaching, a lot of the safety and quality stuff, but also in potentially other clinical roles, such as getting a diploma of palliative care, doing anaesthetics, or doing a second specialty.
Lauren, you're at the beginning of your journey through intensive care training. When you're looking at the program and you see that you need to do a period of time in a regional area, how does that affect you? What are you thinking about in those terms?
That's a good question. And I suppose as an adult who is established in a metropolitan setting, you have just thinking about yourself as a person, your social supports, your family, your friends, and I suppose having a think about how regional time, as enthusiastic as you are, how that fits in or how you kind of navigate that. My bosses last year, they kind of thought of me and approached me and said, we know you're really engaged in social justice issues, in health, and we think this might be something you find really exciting, and equity in health. So, would you be open to this? And I was like, yep, love it. And then it was taking a little bit of a deep breath and being like, okay, let's just put my life on hold for a little bit. And you just do it because I think this is going to be a really worthwhile once in a lifetime exposure. And you, as Penny said, you don't know until you go and you do it. And arriving here, is truly a privilege. Like, it really is. And I've just loved it. And I think it's one of those things that, you know, you don't know what you don't know type thing. And I feel like I'm getting to know the country that I've lived in for my entire life for the first time, in a way. So it's been really personally rewarding and eye-opening and really confronting in a lot of ways. As Penny has mentioned, I'm seeing really sick people that are really young, and there are lots of social determinants of health that feed into that. From a critical care point of view, in terms of my training, I think there's an incredible value in understanding and learning and getting an exposure to what it is to, I think Alice Springs does this incredibly well, to give respectful, culturally appropriate and sensitive care to a very complex, unique patient population. I think it's been easier having the practical support of even just having the agreements between hospitals to facilitate basic things like accommodation that make it at least financially viable to come here, like just even basic things like that. And then I think personally, the other thing I've noticed is that it's wonderfully rewarding to be in a regional centre where you feel very quickly connected to the community. And I think even just having that realisation that, oh, this is a wonderfully rewarding and viable place to train and to work long term is a great thing to find out. I do think about exposure because, you know, rural centres, it's a smaller centre, so there's 4 beds here, six rather, ICU beds plus the HDU beds, as opposed to say maybe 16 plus in a tertiary centre plus the HDU beds. So that's just a smaller case number that you're considering, and there might be you know, less exposure to particular case mix. On the other hand, there's a very different case mix here. So I'm seeing, as Paul mentioned, paediatric patients. We had a 28-day-old patient last week, and we're having, I think that is a really valuable thing for me to see in my junior training. We're also seeing obstetric patients and trauma patients. So in the city, not being at a trauma centre, that's something that that I'm gaining here that I might not in the city. So I suppose those are some of the things that I've thought about a little bit.
Claire, you're not native to these shores, so you arrived in Australia and your first placement was in a regional centre, and it's fair to say that a lot of intensive care throughout Australia and New Zealand is staffed by people who are from overseas. What was it like to walk into that sort of system?
So it was totally different for me because I didn't even think about a career in intensive care. I was basically just looking for a job to stay in Australia, to be totally honest. And I think being regional really influenced me in that because one of the things, I know there's been a lot of chat about like the case mixes and stuff, but one of the things I think is a big benefit of regional centres is you get a lot of one-on-one times with the consultants. So going from as a resident who'd never done any sort of critical care, I hadn't done any anaesthetics, I'd done maybe a little bit of ED, that like everyone does. So yeah, like I had a very early exposure of getting to put lines in, getting to go and, you know, see intubations, things that you wouldn't normally get to do as a junior resident level. And then the other thing is, so yeah, you got that sort of professional bonds, but then also being in a regional place, like I still have a lot of friends from different places that like from Mackay, and then I worked in Darwin and I've been in Dallas as well, sort of been around the regional blocks. But like I think it's a smaller community, so it's not as Lauren had said, if you live in the city, everyone's got their established like relationships and family, and you know you've lived there, whereas it's more a sense of camaraderie, I think, whenever you're regional, because everyone knows everyone and hangs out together. And I really enjoyed that part of it. So
And that's the other side of this coin, I suppose, is that having gone through your training, you're now in a city and studying, have completed your fellowship. How difficult do those social bonds that you've now made in the city make it to returning to regional practice?
Quite the opposite, I think, especially with the lockdowns and things. My husband and I are quite keen to move back somewhere else ultimately, and a large part of that is to do with the lifestyle. We only came down. Stuart's from Melbourne originally, but we came down here for me to do the advanced training part and to do the exams. But we always sort of imagined we would move somewhere to be just having that sort of extra curricular things, like being able to get away and go camping, or things I never thought I'd say when I first moved here. But we actually missed that living in the city. And I think especially now having a family, I think it's like there's not as much I find as attractive in the city. Like you're not going out for dinner or things, whereas you sort of want somewhere that's nice to bring the kids up and have a bit of better weather. The weather in regional places is a big plus usually, but those sorts of, as I say, the things that aren't just work related, and then also being somewhere in a smaller unit. I think that you that you want to have like I imagine like that you want to have relationships with people that you're sort of going to be working with, especially in intensive care. Like you're in work a lot compared to like actually in the unit compared to other sort of career pathways. So I think from what I've seen, there seems to be, even among the smaller units, that everyone seems to get on pretty well. And
Lauren and Claire, question to both of you. What do you think are the things that you need as a trainee that would make it easier for you to initially work in intensive care in regional areas and then subsequently stay on once you've finished your training?
I think Laura made a good point in the financial things. Alice is very well set up for that you get your accommodation provided, because you obviously have your like your wherever you live and things at home, so to keep that ongoing. The having access to teaching programs. I think whenever I was in Mackay, even for the primary, Queensland at that point had it wasn't Zoom in those days, but whatever it was that you can do that, that it was led from Brisbane or one of the tertiary centres, but no matter where you were, you could still participate in the teaching. So that's still very important, because I think in regional places, people tend to be more at different stages in their careers. Whereas if you're in a bigger centre, there'll be a core group that are going to do the primary or a core group that are going to sit the fellowship. So having sort of access to that as well, I think is probably two of the things. Sorry, Lauren, I'll let you talk.
No, I completely agree with everything you're saying. And I think, accommodation was a really big one. And even then, I had to smuggle in my kittens, and because I'm relatively mobile, being, young, single, no kids. But a lot of my other colleagues couldn't swing it with their partner's job or their children, or maybe it's not super simple relocating for a quarter of the year. I think being offered the 3 months, I was like, oh, that is a it's a good length of time for someone that kind of wasn't quite sure what I'd be finding. And then I've got here and now I love it, and I would love to stay for another 3 months, or if it would be 6 months. But interestingly, I think if I was initially offered, would you like to go for a 6-month, 12-month training period, I'm not sure if I would have been brave enough to initially to try it out. So I wonder if there's some degree of flexibility or tie-in or availability for, I don't know, ongoing stay. I think things that would make it easier is I do wonder about, as you mentioned, working long term is, I think it's kind of where in your training you relocate to a regional centre, because I do think it is a balance of being able to have sufficient exposure to, as Paul meant, all areas of critical care that I can feel confident and across. And then if that area maybe wasn't offered in a regional, or we just didn't see it very much in a country community, how I'd be able to meet that gap, or is it possible that if I transition to a regional centre, will I still be an attractive candidate to move back to the city, or is it more of a one-way transition? And that's kind of something that initially I'd be like, I would love to come here and, start my family here and start working here. But does that mean in the scope of my whole career, I might not be able to go back to a tertiary centre? And that might be something I have to consider quite seriously.
Paul, in a similar vein, there is the appearance of a restriction of opportunities when you move to the regional areas. And one of those is about the way that you develop your career as a consultant beyond fellowship. One such avenue, of course, is research, but that's something that you've been able to apply in a regional centre as well. Can you tell us about that?
Sure. I've been really lucky coming back to Alice Springs to have had a very supportive consultant group who have allowed me to pursue some research interests and have allowed some of that non-clinical time to be devoted to that. There are a lot of things about regional Australia that lend themselves to research. The work in regional Australia is quite different. We've started exploring some of that anecdotally just with the conversations you've had with the others in this roundtable. But there's the opportunity to actually document some of that, which is important for epidemiological grounds, on the basis that there is an inequity between capital cities and regional Australia. And I think the same can be said for New Zealand, although the data really only exists currently for Australia. We use the adult patient database, and if I can do a little call out there, because the adult patient database, and in fact all the registries that ANZIC's core hold, contain an absolute wealth of data and information that is really just waiting for trainees and other consultants to tap into to describe intensive care practice. And we've done that in terms of looking at how regional rural ICU in Australia differs from our city counterparts. And it turns out that, what the work that regional rural units do compared to metropolitan units is not actually that dissimilar. The main difference is with tertiary units. So, I certainly hold some of Lauren's concerns that, when you come to a regional place, are you precluding the opportunity to move back to a city? I think the answer is no, because the work with metropolitan and regional units is in fact very similar. So, moving back into a metropolitan unit, I see as no problems whatsoever. Does it preclude moving back into a tertiary unit? I think probably not. I think there would be a period of reminding yourself what that tertiary work is about. But, at its basis, most things are still driven on physiology, and physiology is what we know and do really well as intensivists. It's just the applying that to slightly different patient groups. But I'll move away from the point a little bit, because there are some other really important differences between regional, rural, metropolitan and tertiary units in terms of the type of patients that come in. They tend to be younger. They're far more likely to be admitted emergently rather than electively. And tied in with that, you're slightly less likely to be looking after ventilated patients. Our work, which we published last year, I think it was, in Critical Care and Resusc, also threw out a couple of interesting mortality findings. And it turns out that if you're admitted to a regional rural unit, you seem to have a better mortality outcome than if you're admitted certainly to a tertiary unit and probably also to a metropolitan unit. And the obvious answer to the question why is, well, the sickest patients are transferred to tertiary units. But I don't think that's the whole story. When we were looking at the data, we sliced and diced it in a number of different ways, including excluding inter-hospital transfers if they left the regional unit, and separately excluding patients if they were transferred into a tertiary unit, and then examining everything, including, irrespective of your transfer status. And that outcome was surprisingly robust. And it does make you wonder why. What else is driving that? You know, it could well be that regional units, because of the transfer times to arrive to a hospital, mean that if you're going to die, you're dead before you're admitted to hospital. So people have had their so-called trial of life and have demonstrated some form of physiological stability or lack of fragility, I guess, before they've arrived, and that's what's driving it. It could be that it's a smaller team, and because it's a little more consultant-driven, you know, the very fact that you have a consultant driving things a little bit more rather than a senior reg with that clinical acumen and experience and gestalt that comes with seeing much more things means that you're doing slightly better with foreshadowing what's going to happen, and that's a mortality benefit. Or it could also be that there is perhaps less pressure on regional rural units to admit patients who don't have such a good prognosis. And certainly it's been my experience largely that regional rural people perhaps have a better understanding of the cycle of life, or the circle of life, so to speak, that, you know, that death is an inevitable part of life, and that there is perhaps a bit more acceptance of futile treatment where it is futile, and therefore there's less pressure to admit everybody who has a poorer prognosis. You know, the research that we published last year showed that 1 in 5 patients admitted to intensive cares in Australia are admitted to regional and rural intensive cares, and that's actually it's not a huge amount, but it's enough to be a significant part of the critical care work that occurs in Australia. And if 1 in 5 patients are being admitted to regional rural units, you know, a good chunk of your training time should be spent in those units. And that should be for a number of reasons. One is, you know, regional and rural Australia does suffer inequities, as does regional rural New Zealand, in terms of access to services. We know that regional and rural Australians and New Zealanders access services less. We know they have less ability to be able to see particularly specialists. It behoves us, I think, to address some of that inequity by trying to improve services where they exist. But it also behoves us, once we have left those regional, rural or outer metropolitan areas and gone back to the citadels that are the big city intensive cares, to understand what's happening in regional and rural Australia and or New Zealand. So that when you get the phone call from the regional rural intensivist, the outer metropolitan intensivist that says, I've got this patient, I'm about to run out of what I can do to save them, I need some help, you have an understanding ear on the other end of the phone. One of the things that I find extraordinarily frustrating speaking to a colleague in a big city is after you've told the story, to hear, oh, it doesn't sound like they're going to make it, you should just palliate them there. And if I thought they weren't going to make it, I would palliate them. The very fact that I'm on the phone at 3 a.m. in the morning is because I have run out of options in somebody who I think is salvageable. And I don't think you get that if you haven't seen it and lived it. And that's one of the things that being a trainee in a regional rural area, you get to see and experience and feel that real visceral sensation of, I need help. That's all I'm asking.
Penny, from your perspective as the director of an ICU, what are the skills that an intensivist in regional Australasia requires that are different from somebody who might be at one of the Royals and Saints hospitals in a bigger city?
Look, I think one of the biggest things you need to be is adaptive. You actually need to be flexible, you need to be brave, you need to be able to do the best thing that you can possibly do, even if you don't have all the specialist services around you. and even if it's outside your comfort zone. And that ability to be adaptive, that ability to be brave, and to utilize the skills focuses much more on what is best for the patient rather than what is best for you. And, you know, I think that's incredibly important in your training to actually do. It's really incredibly, as Paul says, incredibly important as a tertiary intensivist to be listening to that from that point of view when you're talking to your rural colleagues. But I think that's the biggest difference. I think you do need more experience in paediatrics because you will come across it and you're quite a long distance from those things. You need to work hard and be able to challenge yourself in adaptive kind of situations where you do need to be a little bit better at your skills. You need to be a little bit better at thinking out through complex problems and working out the best solution.
Rob, as a member of the college board, one of your charters, of course, is to produce the intensivist of the future. How do we know that we're producing what we need for the future? And what are the opportunities that lie ahead for intensivists in regional areas?
That's two really good questions. In answer to your question of how do we know, as I alluded to previously, our training program is a 6-year, but often a decade-long thing. And the only data that we have is some very early data from our pre-2014 curriculum, where clinical directors and trainees were rating themselves and each other on whether they felt prepared for specialist practice. And our ability to repeat that data on a meaningful way on the post-2014 curriculum is going to be something that we're going to have to be looking at in the next year or two. So the honest answer is we don't know. And if people overrate or underrate ourselves, that's going to be an issue too. So what are the college doing? Well, like Claire and many of my colleagues, I was lucky enough to be able to train as a trainee on both sides of the Tasman, including Darwin. And I would suggest that unless you have been 1,500 kilometres away from a PICU or an ECMO circuit, that you've not really lived. So I totally, totally get that. What it did show me is there's huge workforce issues on both sides of the Tasman, which cannot be ignored. In Australia, there's these huge justifiable concerns about the opportunities for a large number of graduates accessing both vocational training programs and, of course, consultant specialist jobs. Whilst in New Zealand, we've got the opposite problem where we've got a relative shortage of applicants from Australia and New Zealand to our transition year or specialist jobs in even the big centres, let alone regional or rural. So as I said previously, the college very basically affects supply, but the reality of how that gets distributed is highly complex. So the workforce issues are still going on. Demand, however, in the rural centres is driven by many factors. Places like Alice Springs and Penny and Alice and Paul and Di and Darwin, that they've demonstrated over many years and huge efforts of the value add that we as intensive care specialists give to an organisation. So, like our pioneers in the Northern Territories or Taranaki or Hawke's Bay. And all that while ANZCA and ASIM have generally phased out their mandated intensive care training time. So the future is going to have to be intensive care specialists in rural region, or at least people who have got some accreditation in that. And then, of course, what can the college do? Well, we can produce trainees, but we can't force them to go and work in regional centres. We can have accreditation standards, but we can't force governments to actually require that as a minimum in rural and regional. And, I've been lucky enough to be in the Parliament this last sort of couple of months asking our government and lobbying governments to say, well, can we actually expect intensive care specialists to be looking after the public? But we've also, as a college, got to have the humility to reflect whether or not our standards are workable and whether they are ongoingly fit for purpose. So there's some work going on there. So the board is working through a raft of proposals driven largely through Penny and Paul and the Indigenous Health Committee that are aimed at promoting a sustainable expert intensive care workforce for regional remote. So we're working with ANZCA to sign off on a dual training pathway with anaesthesia, and that's hoping that we'll be able to go live in 2023. we will need to look at different models of training programs, both in how they're structured, the hub and spoke models, but also that interfaces with employment. But that's just the beginning. So I think, in summary, as a college, we've got to take the humility in saying, is the way we've always done it the way we should do it in the future? Is that adequately achieving equity and sustainability for the rural and regional workforce? So I think there's a huge challenge, and we've got to liaise with universities, with local government, with national government, with ANZICs, with the other colleges to build that in the future.
Lauren, the obvious place to conclude this roundtable is with you. As you sit on the precipice of a career in intensive care, where does regional training and then a career in regional ICU sit for you?
It's honestly, having reflected over this last 2 months on my time here, it's kind of shot right up. It's very attractive. It's a wonderful life in the country. It's beautiful, as I feel like I'm part of a bigger community here, oddly, than I do feel like when I'm in the city and I just have my own personal connections. But here, the person running your trivia night is the radiographer, and, you know, the person you bump into on a hike is, you know, someone you've seen down at the shop. So I think there's a wonderful personal reward to that. I think in my goals and values and the reasons why I am a doctor and the reasons why I like participating in the health system, a lot of them are addressed really highly, serving the community here, which is, as I mentioned, a really special community with complex needs. And I think as an Australian, it's a real privilege to participate in helping address and do some good to that end. I think it's, as I mentioned, it's a viable option. It is an attractive option, but it is about considering the exposure that I need to get along the whole of my training program, and how I might fit that in terms of the longitude of my career. So yeah, just lots to consider going forward. But yeah, definitely, absolutely something that seems like a great goal going forward.
Paul Seckham, Penny Stewart, Rob Bevan, Lauren Cox, Claire Corrigan, thank you for joining us on this roundtable.